we'll discuss part of HER2-positive breast cancer related to the metastatic disease. To start with, we need to understand HER stands for human epidermal growth factor receptor. So we have a family of HER receptors. They all have many things in common. They have extracellular domain. They are surface receptors to start with, and they traverse the cell membrane through the transmembrane part, and then we have intracellular part, which is having tyrosine kinase activity. In essence, we have four receptors. HER1, which is also known as epidermal growth factor receptor. You know that, of course, in lung cancer, that's the HER1, HER2, HER3, and HER4. And the extracellular part of the receptor, it needs a growth factor in order to be activated. So let's have a look on what happens actually when we have a growth factor. The two receptors will come to join each other. This process is called dimerization. If the receptor is from the same type, that's to say HER2 and HER2, it is called homodimers, but usually it is heterodimers, where HER2 will join other HER receptors, HER1 or 3 or 4. Importantly, when we have dimerization of the receptor, this will phosphorylate the tyrosine kinase part, and this phosphorylation is responsible to induce intracellular signaling cascade. We'll have a look on that, but I wish to tell you that HER2 is the preferred dimerization partner of all the HER family receptors, as it induces more potent signaling. Anyway, that's the usual scenario. HER2 will dimerize with other HER receptors in the presence of growth factor. This will activate two major pathways: the MAP kinase pathway, which include the RAS, the RAF, the MEK, and ERK, and PI3 kinase pathway, which includes PI3 kinase ACT and mTOR. This will end by signals to transcription of the cell cycle genes. That's to say, they will activate the cell cycle and produce several proteins related to apoptosis, which is augmenting the survival of these cells, angiogenesis, migration. Migration stands for, of course, in cancer, it stands for metastasis and cell proliferation. So physiologically, we need the HER2 signaling for many things, for the repair of different tissues. So that's very crucial in physiological situation. Importantly, when the physiological function is over, this pathway will be switched down by many tumor suppressor genes. The most known of them is the P10 tumor suppressor gene, which will close the signaling of PI3 kinase pathway. In normal cells, actually, we have something like 20,000 receptors per cell. That is in each cell, actually, that's normally present. What will happen in breast cancer is that we have what we call HER2 gene amplification. So we have more gene copies in the DNA that will lead to overexpression, production of a large number of HER2 receptor that will reach up to 2 million HER2 receptor per cell. Very, very high number. They are all signaling unopposed. This will increase the proliferation of the cancer cells and the aggressiveness of the cancer cells. In the clinic, we have known more than 30 years ago that compared to HER2 negative, HER2 positive early breast cancer will have much more relapses within the first 5 years. As you can see, the relapse rate is much higher in HER2 positive, and the sites of metastasis actually are different, much more lung metastasis and liver metastasis, and brain actually is at least 10 times higher than HER2 negative. If you treat without targeting therapies to HER2 receptor, that was the survival of patients with HER2 negative versus HER2 positive. Very clear that HER2 positive, it has poorer prognosis compared to HER2 negative. So what we know about HER2 positive, in essence, it is a disease of poor prognosis because of more visceral metastasis, especially to the lung and brain. Early relapse, even if you give very intensified chemo or new adjuvant chemo or neoadjuvant. We have one study, prospective study actually, that compared very intensified chemotherapy neoadjuvantly in patients with HER2 negative and HER2 positive, and that was the outcome. This was before the utilization of trastuzumab or Herceptin. You can see after the first 1.5 years, the patients in the HER2 positive population, in spite of very intensified chemotherapy, they go and progress rapidly, much more than HER2 negative. Thirdly, they have less benefit of hormonal therapy, and this is one of the studies to show us the outcome of first-line letrozole in patients with HER2 negative, that's in blue, versus patients with HER2 positive. Our group was part of this study, that's the Electra study, and other studies could show us similar outcome, that HER2 positivity is a biomarker of endocrine resistance, actually. Why is that? Because actually the cell proliferation is HER2 driven. So it is very logic that we try to target the HER2 function. And the first attempt to do so was to construct a monoclonal antibody against the extracellular domain of the HER2 receptor. And when you do that, you antagonize the signaling properties of HER2 positive in breast cancer cells. And again, trastuzumab does not only do this, but it has an immune-mediated effect via the Fc part of the monoclonal antibody. Here is the Fc part. The Fc part is able to interact with the Fc receptor of the natural killer and macrophage to induce antibody-dependent cell-mediated cytotoxicity. So trastuzumab actually is a cytotoxic drug via its immune-related mechanism of action. The first study that could show us that when you add the trastuzumab to chemotherapy, it could improve dramatically the progression-free survival and the overall survival in the first-line setting of HER2-positive metastatic breast cancer. That was a breakthrough publication, actually, which brought very good news to patients with HER2-positive. Can we use trastuzumab as a single agent? The answer is no. Because this target therapy, in spite of targeting well the HER2 receptor, but as a monotherapy in the first-line setting, as you can see, the overall response rate is only 26%, and the time to progression is less than 4 months. So it is always the practice to give trastuzumab with other chemotherapeutic agents or with endocrine therapy in selected cases. Back to something we learned many years ago, that if you fail trastuzumab and chemotherapy in your patient, then keep the pressure on the HER2 signaling. The concept of HER2 addiction by cancer cells is there. The cells are so much addicted to the proliferative activity of HER2 signaling. So you need actually, after failure of trastuzumab, to give anti-HER2 therapy all the way. And we learned that from a German trial that was published around 15 years ago. They brought around 180 patients with failure after trastuzumab. Usually, when you fail a drug, when your patient fails a drug, you need to change the drug. But this is not the case in HER2 positive patients. Here in this study, we have seen that patients after failure of trastuzumab, they were randomized to receive capecitabine monotherapy or capecitabine plus trastuzumab again. And you can see if you keep the pressure on HER2 positive cancer cells after failure of trastuzumab by trastuzumab again and capecitabine, this was much better than capecitabine again in progression-free survival and in overall response rate. So the concept of HER2 addiction, we need to remember that after failure of one line of anti-HER2 therapy, you have to give another line of anti-HER2 therapy, including to re-challenge by trastuzumab once again. We need to have a hint on what the pathologist will really do for the sake of giving you a report of HER2 positive or HER2 negative. Where do we search within the cell? The receptors are on the cell surface, so you can detect them by immunohistochemistry, while the gene, the HER2 gene, which we have many copy numbers because the oncogenic event actually is HER2 amplification, more copy numbers of the HER2 gene actually in the DNA. So in order to check on that on the copy numbers, you need to check the amplification of the gene by any technique, including in situ hybridization. You have many techniques for in situ hybridization actually. In essence, we have a score from 0 to 3, and we search for the brown color, as I'm going to show you. The 0 is no staining, no brown color at all, or very faint brown color, extremely faint brown color in less than 10% of the cells. So you hardly see brown here. That's the 0. That's definite negativity. And 1, you have again faint staining that is incomplete, but in more than 10% of the cancer cells. Here you start to see some brown here and there, but it is extremely faint. For the score 2, you have more brown, more staining of the cancer cells in more than 10% of the cells, but it is not complete staining. But you can see more staining, more brown coloration in immunohistochemistry +2, and now you will see the score 3, which is strong, complete membrane staining in more than 10% of the tumor cells. Now you can appreciate the difference. Actually, that's how the pathologist will see the slide. We know that the +3 is a definite HER2 positivity. Score 0 and +1, it is definite negativity. In the middle, that is score 2, we call it equivocal. We're not really sure if it is positive or negative, because we knew from several studies that some 30% at least of this +2 tumors, they are actually HER2 positive. How we can perform the confirmation? Now you have to go for the in situ hybridization. And this should be done automatically as a reflex test. I mean, the pathologist should do it without we ask for it for this in situ hybridization testing for score 2. In situ hybridization is that you see how many copy numbers of the HER2 gene that is in red, and how many copy numbers of the green control, which is the centromeric portion of the chromosome number 17. Here you can see that you have 2 copies of the green and 2 copies of the red. So here there is no amplification of HER2, that's negative. But if you see plenty of the gene copy numbers, plenty of the red for each 2 green centromeric portion of chromosome 17, here the ratio is more than 2, so we used to consider it as positive. Now the situation during the last ASCO CAP guidelines, because this these publications actually they come from the conjoined work of the ASCO American Society of Clinical Oncology, that's the clinical part, with the College of American Pathologists, that is the pathology part, and they put guidelines for the whole world actually to follow. If you have immunohistochemistry +2, you do the ISH assay. Now we have 2 things. You have the ratio, if it is more than 2 or less than 2. If it is more than 2, now you search for the number of the red dots, which are the HER2 copy number genes. This is certainly ISH positive, what we call HER2 positive. And on the other extreme, if the ratio is less than 2 and the copy number of the HER2 is less than 4, that is definite negativity. And all the other scenarios in the middle is you are still in the gray zone, and you need to discuss with your pathologist how to confirm the positivity by other biopsy or by repeating the same procedure once again. I will not go any further, but I wish to tell you that at the present time, we have known that HER2 expression is a continuum, as you can see, and with increasing the brown color, you will have a definite increase in the messenger RNA. And that is brought the term of HER2 low, which includes those with 0 and includes scoring 1 and 2 with the ISH negative. We learned from trastuzumab early studies that this drug, although we never thought it is a cardiotoxic drug, but we knew that it has cardiotoxicity, that is the incidence of heart failure in different studies, the pivotal studies of Herceptin. You can see as monotherapy in the first line, the cardiotoxicity is low in the range of 2%, but in the second and third line, where the majority of patients receive the anthracycline before, that's again trastuzumab monotherapy, the toxicity, cardiac toxicity is seen in something like 8% of the population. But if you combine with chemotherapy, and if this chemotherapy is anthracycline, now you can see that the cardiotoxicity is extremely high, unacceptably high, and that's why the combination of trastuzumab with anthracyclines is, especially doxorubicin, is practically contraindicated. But again, if you give even paclitaxel, the cardiac toxicity with paclitaxel is there in the metastatic phase. So Importantly, whenever you give trastuzumab, you need to monitor the cardiac function, and we have several guidelines for that, how we monitor the cardiac function during the treatment by trastuzumab. Why the cardiotoxicity with trastuzumab? Actually, later on, we knew several biological tricks related to cardiotoxicity of trastuzumab. HER2 receptor actually is vital for the cardiac muscle development during embryogenesis. But after birth, HER2 signaling is essential for the growth, survival, and inhibition of apoptosis of cardiac muscle cell, the cardiomyocytes. Once the heart is subjected to any stressful condition, for instance, severe hypertension, anthracycline use, myocardial infarction, physiologically HER2 signaling is activated in order to promote the cardiomyocyte survival and reduce the risk of cardiac damage. And this reduces the cardiomyopathy induced by different stressful conditions, including, of course, doxorubicin treatment. So in essence, HER2 signaling is needed for the integrity of the cardiac muscle function. And trastuzumab, by inhibiting HER2 receptors, it leads to loss of HER2 survival pathway responsible for the cardiomyocyte recovery after doxorubicin or any other stressful condition of the heart. And that is the cardiac toxicity rate in one of the adjuvant trials where you give anthracycline and paclitaxel. That's the rate of cardiotoxicity over the first 3 years. And that's the rate of cardiotoxicity. Here we mean heart failure. If you give the same chemo with the trastuzumab. So there is a significant increase in the cardiac toxicity, actually, in spite of the fact that trastuzumab was given with paclitaxel, and of course it was not given with AC. Whom you suspect the development of cardiotoxicity. We have beautiful subgroup analysis in this study that showed us that for the left ventricular ejection fraction, if it is on the low side of normal, from 50 to 54, and if your patient is more than 50 years of age, the incidence of cardiac dysfunction is around 20%, while on the other hand, if the baseline left ventricular ejection fraction is 65% or more, and if your patient is young, below the age of 50, the incidence of heart failure is extremely low, less than 1%. So you have to put that into consideration. You have to do more evaluation for elderly patients and for those starting with a relatively low left ventricular ejection fraction. We published this several years ago, the difference between anthracycline-induced cardiotoxicity and trastuzumab-induced cardiotoxicity, which is what the first is type 1, that's more serious with anthracycline. It is dose-dependent, and it is cumulative, lifetime cumulative. You should not exceed a certain dose, which is around 400 milligrams per square meter of anthracycline, while cardiotoxicity of trastuzumab is not cumulative, is not dose-dependent. You can give for years and years without having any cumulative toxicity. Reversibility is another important thing. Reversibility of anthracycline cardiotoxicity is often not reversible or not completely reversible, certainly, but it is potentially completely reversible in more than 75% if your patient developed trastuzumab-related cardiotoxicity. In the early days, the group of MD Anderson Cancer Center, they used to practice cardio a cardiac muscle biopsy to see the damage of the cardiac muscle with anthracycline, and they found in the biopsy specimens of the cardiac muscle extensive necrosis when in patients treated with anthracycline, while no similar structural damage is seen if you give trastuzumab and have a cardiac biopsy. Lastly, in our group and in other groups, we tend to give doxorubicin as 24 hours infusion because we have several data to tell us that this reduces significantly the cardiac damage by anthracyclines. So scheduling of anthracyclines by continuous infusion actually can lead to a decrease of the cardiac toxicity, while with trastuzumab, we don't need to do that because it is not related to the mechanism of action of trastuzumab as a cardiotoxic agent. How we prevent this? We have cardiac toxicity related to anthracycline, related to trastuzumab. We have the Canadian group. They published this several years ago. It is a placebo-controlled, double-blinded, multi-center trial, including around 100 patients treated by trastuzumab. Patients randomized to receive a beta blocker, an ACE inhibitor, or placebo, and at baseline, all patients in the three arms, they have left ventricular ejection fraction more than 50%. Importantly, in the placebo arm, the drop of, there was a significant drop in ejection fraction, which was not seen in patients treated by ACE inhibitor, and more even for those treated by beta blockers. And the take-home message in this from this small but important trial is that you can give preemptively a small dose of beta blocker. Usually we give Concor at 2.5 milligrams. This does not reduce the blood pressure, and it can really help you to reduce the development of cardiac events with trastuzumab. To this end, I wish to tell you that an Italian group last year, they provided similar approach even for patients treated by anthracycline in early breast cancer. And again, they used the same policy to give beta blocker or ACE inhibitor or the combination of both versus placebo. And they monitored at different time points the effect on left ventricular ejection fraction. As you can see, the upper curve, the blue one, is those who were treated by the beta blocker followed by the ACE inhibitors, was those who did not receive any treatment. That's the placebo. You can witness a considerable drop in left ventricular ejection fraction. So now we started to adopt this approach. It is very important, and of course it applies for your patients with treated by anthracyclines for lymphoma. However, the best way to get rid of trastuzumab-induced cardiotoxicity is not to use the dangerous drug. The dangerous drug, of course, is anthracyclines, and we have seen in the BCRG study, our group was part of this. They compared the AC with Taxotere versus AC Taxotere plus Herceptin versus Taxotere, carboplatin, and Herceptin, which is non-anthracycline containing regimen. And they reported in a beautiful way, actually. Our group, again, was part of this study. That is how it goes, the dynamics of cardiac toxicity. If you give AC Taxotere, that's the blue curve, that's the yellow curve. And if you add the Herceptin to this regimen, that is the blue curve. That's how it goes during the first 10 months. The cardiac ejection fraction, left ventricular ejection fraction, drops significantly in patients who received Herceptin, and this is the effect of time actually for either group. Over time, the patients who received the Herceptin, they start to improve over time. They did not go to baseline, of course, but look at the effect of anthracycline. It will more and more over time induce cardiotoxicity that is in the Herceptin-free regimen. But the third arm, which was anthracycline-free, the TCH regimen, Taxotere, carboplatin, and Herceptin, that was the changes in the left ventricular ejection fraction. You can see a very minor decrease in the beginning, but the recovery occurs very early. So that's why in our group and in many groups actually we prefer not to use anthracycline-based regimen unless in very certain circumstances where you have, for instance, severe toxicity from platinum regimen. Anyway, another problem with trastuzumab, it's not with trastuzumab actually, but with treatment with trastuzumab in the metastatic phase, that we started to see more and more brain metastases. Once again, our group was among the very first groups to report the high incidence of brain metastases in patients treated with the trastuzumab plus chemotherapy in the metastatic phase. The range is from 25 to 50%. Of course, we knew later that the disease actually, biologically speaking, it has a very high tendency to colonize in the brain with the HER2-positive malignant cells. And that's why when your patient will live longer because you control the systemic metastasis, then they will develop more and more brain metastases across the prolonged survival of these patients. The problem of CNS actually is a real one. We will discuss it, but not today. We'll throw some light on it today. But trastuzumab was a beautiful drug actually, but we needed to develop other drugs to improve over trastuzumab. And when you wish to develop a better drug, you need to understand few things from preclinical and in models and in vitro studies. So we published this 15 years ago or more. That's a review on the resistance to trastuzumab. It is related actually to dimerization with HER3. So HER2 preferentially, in breast cancer, it dimerizes with HER3, and HER2 and HER3 heterodimer actually has the most potent stimulus for development of breast cancer and for activation of PI3 kinase pathway, which is one of the main causes of resistance to trastuzumab treatment. So it was important to try to block the HER2-HER3 interaction. In fact, trastuzumab, it binds in certain domain. We call it subdomain or domain 4, but it does not actually block the dimerization domain, which is connected to HER3 dimerization. So trastuzumab does not affect HER2-HER3 dimerization. So if you wish to stop this, actually, that is where the Herceptin will come, and that is where the dimerization of HER3 will come. Herceptin will come here, and then if you have pertuzumab, pertuzumab is a monoclonal antibody against another part of the extracellular domain of the HER2 receptor. It is a monoclonal antibody against the dimerization part of the receptor. So this will stop the HER2-HER3 dimerization. And by doing this, theoretically speaking, you will be able to improve over trastuzumab alone. But of course, you need to prove this in a clinical trial. And that's why the Cleopatra study was designed. Patients with HER2-positive metastatic breast cancer, the majority actually were trastuzumab naive. They never received any trastuzumab before, and they were randomized to receive docetaxel plus trastuzumab versus docetaxel plus trastuzumab and pertuzumab. And you can see that the progression-free survival was significantly better in favor of the pertuzumab arm, and the overall survival, that was improvement of overall survival by around 15 months in the median overall survival. So this regimen, actually, we call it always the Cleopatra regimen, is the standard of care as first-line treatment in the majority of cases still now. Importantly, the duration of response was pretty long in the pertuzumab arm. The response rate was 80%, very high response rate versus 70% without pertuzumab. Again, the toxicity profile was mainly related to the presence of docetaxel with pertuzumab. You can see diarrhea actually was pretty high. You have to pay attention for that. And drug rash, once again, was increased, and so was the mucosal inflammation. The cardiac toxicity, we were expecting to see more cardiac toxicity, and we'll spend more time, if you wish, on that. But actually, the combination of trastuzumab plus pertuzumab did not have a higher cardiac toxicity compared to trastuzumab and docetaxel alone. It was 1.8 for the placebo arm versus 1% in the pertuzumab arm. The toxicity of the combination related to docetaxel, actually, it prompted many groups, including our group in Asr al-Aini, actually were part of the on this study, pursue study that tried to see what is the best what we call taxane to combine with trastuzumab, pertuzumab in terms of efficacy and toxicity. And it was not a randomized study, it was cohort studies, included 3 cohorts, docetaxel, trastuzumab, pertuzumab, paclitaxel, or nab-paclitaxel, trastuzumab, pertuzumab. That is the performance. If anything, the paclitaxel was at least as good as docetaxel in the progression-free survival in hormone receptor positive and hormone receptor negative. And the overall response rate was identical to what we have seen in Cleopatra study, around 80%. Importantly, we knew from this study that if your patients have received prior trastuzumab in the adjuvant or neoadjuvant setting, the performance of this regimen is less. The progression-free survival is 15 months only versus 23 months for those who never received adjuvant or neoadjuvant trastuzumab. More and more, the site of metastasis, and you have to pay attention that if your patient have no visceral disease, then and they have received the prior trastuzumab, the progression-free survival is 24 months, while if they have prior trastuzumab and they have visceral disease, the progression-free survival is only 13 months. So we knew from this study a lot about what you expect actually when you discuss with your patients and your colleagues the outcome expected from the trastuzumab, pertuzumab, and taxane in the first-line setting. The tyrosine kinase inhibitor, actually, they are small molecules. They were developed to overcome the problem of brain metastasis because they have the potential benefit of crossing the blood-brain barrier. And we have 4 drugs, at least 4 approved: lapatinib, naratinib, pyrutinib, and tucatinib. They all block the tyrosine kinase part of the receptor, but they are not the same. They have different molecular weight, as you can see in the bottom of the slide. Lapatinib and naratinib and pyrutinib, they also block the EGFR, which is HER1, while naratinib and pyrutinib, they block the HER4 as well. So they are called the pan-HER blockers. Let's see the outcome anyway. Lapatinib is the first of them. It blocks HER1 and HER2. It has a much more potent inhibition of HER2 signaling, more potent than trastuzumab to inhibit the signaling. But of course, it is devoid of the immune mechanism related to the action of trastuzumab, and it is a substrate of P-glycoprotein, which is a drug resistant protein, and that's why it doesn't maintain a long-term remission. Actually, it has a small molecular weight, less than 1 kilodalton. Remember, trastuzumab is 145 kilodalton, so it's much more smaller than trastuzumab. Lapatinib induces HER2 accumulation, and this is very relevant. We'll see the importance of that in a minute. While trastuzumab induces HER2 receptor internalization, and that's why their combination is thought to be synergistic. Lapatinib, although the target is the same, it is always the HER2 receptor, but lapatinib actually, we knew from the early studies of lapatinib that the cardiotoxicity of lapatinib does not exceed 0.5% as congestive heart failure, compared to 4 to 7% with trastuzumab. So we have many biological explanations for that, but importantly, lapatinib and other TKIs, actually, they have much less cardiotoxicity compared to trastuzumab. The first randomized study with lapatinib was after failure of many lines in the metastatic phase, including trastuzumab-based regimens in patients with HER2-positive breast cancer. Lapatinib plus capecitabine versus capecitabine alone, we have seen improvement in the progression-free survival, but we did not see significant benefit of overall survival. Our group was very interested for the effect of lapatinib actually in brain metastasis, and in this publication we published 12 years ago, we analyzed all the studies that utilized lapatinib plus capecitabine in the treatment of brain metastasis. Of course, prior radiotherapy to the brain always will make the outcome less favorable. But you can see that the CNS responses, they are not really impressive. They range from 20 to 30, 35% in previously treated patients. But we have one single study from France that utilized the combination of lapatinib plus capecitabine as first-line treatment without prior radiation to the brain, and they reported the overall response rate of 67% with a median progression-free survival of 5.5 months, which is, in my opinion, impressive. But we did not have a supporting other study to support this results. Is lapatinib equivalent to trastuzumab? The answer is no, it is not equivalent. We have a study from the NCI Canada to give lapatinib plus taxane versus trastuzumab plus taxane, you can see in the first-line setting that the performance of trastuzumab plus taxane is much better than lapatinib plus taxane. So that was actually a disappointing study for lapatinib. And later on, the French group in the study called the Cerebral study, they compared lapatinib plus capecitabine versus trastuzumab plus capecitabine as first-line treatment. As you can see, the upper curve is trastuzumab. It was significantly better than lapatinib in progression-free survival and overall survival. But in the second-line setting, lapatinib plus capecitabine was equivalent to trastuzumab plus capecitabine. That's why it was very clear that lapatinib data cannot really mount for the first-line treatment. Trastuzumab is the standard of care or trastuzumab-based regimen, while lapatinib is for the second line or beyond in therapy. But from the lab, once again, we knew, as I told you, that lapatinib induces accumulation of the receptor, of HER2 receptor, while trastuzumab induces a downregulation of the receptor, induces internalization of the receptor. So if you treat your patients with, that's the HER2-positive tumor, and that is the tumor after treatment by trastuzumab, you see less brown color because the receptors are internalized. They are not present on the cell surface, what we call downregulation of the receptor. While if you treat the HER2-positive tumor by lapatinib, you see more and more darkening, more and more the brown color, which means accumulation of the receptor. So it was thought that if you bring lapatinib with trastuzumab, then you will increase the antibody the antibody dependent cell-mediated cytotoxicity, because it depends on the presence of high number of the receptors. And in the animal models, if you give the combination that is in red, that is trastuzumab alone, that is lapatinib alone, the combination is the winner. And we have seen this in a clinical trial where the patients received more than 5 lines of treatment, and they were treated by lapatinib monotherapy or lapatinib plus trastuzumab, in spite of the fact that they failed immediate trastuzumab before. And you can see that the combination is much better than a single agent. And later on, we knew that this combination can induce what we call more complete inhibition of the HER2 network signaling. In hormone receptor positive HER2 negative, in hormone receptor positive HER2 positive, we have the alternative study which utilized the combination of lapatinib, trastuzumab plus aromatase inhibitor versus trastuzumab and aromatase inhibitor, or lapatinib and aromatase inhibitor. The primary endpoint actually was the combination of trastuzumab aromatase inhibitor versus the triplet of lapatinib, trastuzumab, aromatase inhibitor. And we have seen that the triplet combination which was extremely safe. Actually, it could double the progression-free survival, and it could improve dramatically the response rate from 13% to 31% with the combination, with a very strong trend towards improvement in overall survival.